So my name is Taylor. I'm an assistant professor at the University of Illinois Chicago in the College of Pharmacy in the Department of Pharmacy Systems, Outcomes, and Policy. And just as a general guide, I'll kind of touch upon some key points about kind of my journey and my interests, but also talking about options for students and trainees, as well as leaving some time for a facilitated discussion at the end. So a little bit about me. I am a pharmacist by training. I went to the University of Pittsburgh for pharmacy school, and now kind of I'm in this role doing research. And my long-term goal is to markedly improve patient safety through a systems-based collaborative health services research. But if I'm being honest, I didn't really start off caring about patient safety. I cared, as in, in the sense that, we all care about our patients and their safety, but that wasn't what I was really passionate about. What I really cared about was community pharmacy. I loved community pharmacy and interacting with the patients and being accessible, and that's what I wanted to do. But it became very apparent over my years and my experience that pharmacists weren't happy. And then before I knew it, I was sobbing before going into shifts and dreading getting yelled at and feeling overwhelmed and calling my mom crying, saying, I don't think I want to do this anymore. And so these pharmacists and me, we were all suffering. And so I thought, what can I do to solve whatever this problem is? And so, I kind of worked up in my mind that I was going to become, the pharmacist, and then I was going to become the pharmacy manager, and then I was going to become the district manager, and then I was going to become a regional manager. And with my enthusiasm and with my excitement and with my love for community pharmacy, I would solve all of the problems and everyone would be happy and no one would be crying anymore. But, a faculty member when I was in pharmacy school told me, in order to really solve these problems, you should consider going to graduate school and studying human factors, ergonomics, and systems engineering. Now, I knew nothing about ergonomics. I knew that it kind of related to chairs and work systems and looking at computer screens, but community pharmacists really didn't sit down and didn't use chairs anyway. So I was like, I don't know what this has to do with anything. So I'll share with you a little bit about what I learned. So human factors and ergonomics, they're often used interchangeably or as a unit. So it can be human factors or ergonomics or human factors and ergonomics, HFE. And really, it's the scientific discipline concerned with the understanding of interactions among humans and other elements of a system, and the profession that applies theory, principles, data, and methods to the design in order to optimize human well-being and overall system performance. And when they talk about the system, this represents the physical, the cognitive, and the organizational artifacts that people interact with. So within this system, there can be the technology, software, medical devices, it can be a person, or it can be a whole team or an organization. It can be policies that are in place, or the culture, or guidelines, even things like the physical environment and the lighting that's available. It's all of it. And so ergonomists focus on the design of systems so that they fit the needs, abilities, and the limitations of people, with a real emphasis on limitations. The key idea underlying human factors is that humans are humans. We're not perfect. We make mistakes. We get tired. We get excited. It's also sometimes called human factor psychology because it's so involved with how humans are humans and how we interact with the world around us, especially at our jobs. So I was hooked. I wanted to study human factors and pharmacy. And so this led on a whole journey kind of to graduate school where I got my PhD in health services research, so related to healthcare in pharmacy. But I also got a PhD minor in human factors and industrial and systems engineering, really looking at job design and taking what can be learned from other industries like the military, truck drivers, aviation, and then applying that to pharmacy, specifically community pharmacy and the job design. And so throughout graduate school, I became introduced to human factors, right? And these people love theories, theories, models, and frameworks. And as a visual learner, I loved theories because it was a very kind of systematic way to look at and evaluate and kind of visualize these different concepts. In some circles, especially in the dissemination implementation science place, they call them TMFs. So if you're really cool, you can call your theories, models, and frameworks TMFs. But one of the main models used in human factors is called SEEPs, which is the Systems Engineering pioneering initiative for patient safety. And you can tell how old it is based on the clip art that was used whenever it was published. But essentially, it's also based on a model that you may have seen before, which is Donna Bedian's model of quality. It includes the structure, process, and outcomes. And so according to SEEPS, there is a person that performs a range of tasks using various tools and technology. And the performance of these tasks occurs within a certain physical environment and under specific organizational conditions. And then the work system in which care is provided affects both the work and the clinical processes that are done, which in turn influence the patient, employee, and organizational outcomes of care. You have your structure or your work system, your process, and your outcomes. So this was it. I knew that my suffering pharmacists were here. They were in the outcomes section. And I knew that if I wanted to know why they were suffering and wanted to change it, I would have to look to the system. And the model postulates that the fact that these pharmacists were sad and their well-being was poor, this likely impacted the quality of care that they were able to provide, and in turn, safety. And what human factors in healthcare really cares about and really looks at is safety for the patient and for the employee, because again, we know that humans are fallible, we make mistakes, but there's also a lot of benefits to the decision making that humans are able to provide. Okay, so you may say, like, Taylor, what about occupational fatigue? What does this have to do with it? And so a lot of that was luck. A lot of that was driven by what my advisor was interested in and some of the folks at the University of Wisconsin-Madison who were doing work in occupational fatigue in nurses. And so figuring out ways to transfer that into pharmacy. So let me tell you a little bit about occupational fatigue. To put very simply, fatigue is your body's biological signal that it needs to rest. We've likely all felt fatigued at some point, whether it was, we pulled an all-nighter writing an exam or we ran a marathon. It's kind of this universal feeling that we've likely all felt at some point. Throughout the presentation, I might shorten occupational fatigue to just kind of fatigue. But in the context of this presentation, I kind of mean the same thing. It's this need for our biological rest, a recuperative rest that occurs during, after, or is in any way related to the work that we do. And this fatigue can be described in many ways. It can be described as physical or mental, acute or chronic. It can be described as active, which is similar to that kind of feeling that you get after you've been, or while you're sitting in traffic and you're gripping the steering wheel and you're trying to manage all of these different sensory inputs of, the traffic and the people and the merging and the radio. But it can also be passive. So that feeling of drowsiness that you might get when you are driving on a really open road and you have cruise control on and there's no traffic and you find yourself dozing off. Fatigue has also been described as a lack of energy as well as sleepiness. As a note, it's not just sleepiness. There's muscle fatigue. There's kind of all of that goes involved with it in addition to sleepiness. And so we kind of have this big picture now of what fatigue is. And another way that I like to think about it, especially with regards to occupational fatigue, is this balance between our work demands. So that's all the things that we have to do and the time that we have to do them in, and our capacity to do the work. So that's all the resources that we have, maybe our personal bandwidth or the resources within our work organization. And fatigue often occurs when our work demands outweigh our capacity to do that work. We get feelings of excessive workload and fatigue as a result. So one example that I often give is, maybe a pharmacist has 75 prescriptions in the queue and 5 people waiting in the store for COVID vaccines, and the drive-throughs backed up with COVID tests. And on any other day, it wouldn't be a problem. But today, that pharmacist, they didn't get enough sleep last night because they have a new puppy and they have to take it out every hour. They forgot their coffee and they had 3 technicians call off all before 10 a.m. So you can see now how we've tipped this scale between this balance of demands and capacity. And so we know that fatigue has been studied in other professions like transportation and heavy industry. It's been studied in nurses and even in physicians, and it's been shown to have negative outcomes. On the employee, it can cause reduced job satisfaction, increased risk for health problems and injuries, even greater likelihood of getting into a car accident on the way home from a shift. I actually had a colleague tell me once that, they worked with someone in pharmacy school who was asked to work a double shift at their pharmacy and had worked for, I don't even remember, I think 20 plus hours. That individual was so fatigued and exhausted that on their way home, they actually fell asleep behind the wheel and crashed and passed away. So this is a real kind of occurrence that can affect a lot of people. With regards to our patients, there's decreased reaction time when their healthcare professionals are fatigued, decreased diagnosis time, increased errors, as well as just an overall decreased experience. We can think about how willing we are to interact with someone at the end of a long day. And then for the organization and for the employers of these fatigued healthcare professionals, there's a decrease in meeting metrics and the quality of care that's provided. There's an increase in employee turnover of people leaving, not just limited to healthcare, but it's been estimated that workers with fatigue cost employers $100 billion in health-related lost productive time in a year. So we know that occupational fatigue in these other professions is bad. We might also be able to guess that occupational fatigue in community pharmacists is also bad and also plays a role. So when I say community pharmacists, I mean what many people associate with a typical retail pharmacy. Places like the national chains or small independents where pharmacists literally have direct access to their patients and their communities. I'm not saying that fatigue doesn't exist in other types of pharmacists, but this is just what I was really interested in. And community pharmacists, we know, are crucial healthcare professionals. They've been touted as the most accessible healthcare professionals, especially in rural areas where patients may not have access to a doctor's office. But community pharmacists work in really unique environments. It's kind of this mixture between healthcare and non-healthcare retail establishments. People don't make appointments to go pick up prescriptions. There's a drive-through, which often kind of makes it relatable to fast food. And there's information coming from everywhere. You have drop-off windows, pickup windows, faxes, electronic health records, or electronic prescriptions, and you have telephones ringing, and it can make it really hard to predict our work, but also manage all of these different inputs. In the AACP Pharmacy Workforce Survey in 2019, 3 out of 4 community pharmacists work their workload levels as high or excessively high. And let's not forget, these pharmacists are usually standing for their entire shifts. Until recently, pharmacists didn't get breaks. So they would go for 10, 12, 14 hours without a designated lunch break, without sitting down, sometimes without even really having time to go to the bathroom. And so, especially when we consider COVID-19 and work demands increasing and their impactful role in their patient safety, we can say that there's a real critical need to examine occupational fatigue in community pharmacists. So to further make sense of this, kind of all of these different concepts of fatigue and capacity and demand and safety, and to really articulate this problem, I went back to my conceptual models and to my visualizations and reapplied SEEPs to show that there's the work system, all of these demands, and also the resources and capacity, which impacts the pharmacist processes and how the work gets done, which ultimately, the interaction of this person within their work system results in outcomes such as occupational fatigue, and then further downstream outcomes such as patient safety issues and burnout or turnover. I want to make a quick distinction between fatigue and burnout because they often kind of get conflated. So you can think of fatigue, it's on a scale of acute to chronic, but I often think about fatigue as something that can be overcome. Even if you have to go on a vacation, you can usually come back feeling restored or restful. Whereas burnout is a kind of chronic mismatch between a person and the job that they're doing, has these feelings of, lack of personalization and feeling of lack of accomplishment and emotional exhaustion that can't really be overcome by going on a vacation. A lot of times folks that are experiencing burnout come back from vacation and feel worse because they have to go back to the job that they don't like doing. And so in order to overcome burnout, you really have to think about a really drastic change. This is leaving the job or a really drastic change in the profession. But there's been evidence to show that if we can intervene at the fatigue level before it gets to burnout, we can somewhat prevent burnout from occurring if we can reduce fatigue. And so it's kind of one of the distinctions between the two. But so the systems-based approach also leads us to research questions that we want to know. Maybe how can we describe and measure occupational fatigue at community pharmacists? What does this look like? So a lot of my work has been in this area, kind of conceptualizing and measuring fatigue. There are 5 main ways that you can measure fatigue, and I've used 2 so far, subjective measures like surveys or instruments, as well as interviews. And then I've also used biomathematical measures, which are essentially actigraphy devices or kind of like your Fitbit that gives you your sleep ratings, or Apple Health, which can tell you how well you slept, can give you some specific insights into aspects of fatigue, like sleepiness or even the number of steps, to give you an idea of workload and kind of your demand. So our framework also can help me study questions like what personal or work system characteristics cause or lead to fatigue, and what factors can help prevent or even cope with fatigue. And so this was kind of the basis or one of the bases for my dissertation. So I'll just share a little bit of those findings with you. I was interested once again in studying community pharmacists practicing in Wisconsin, and the subjects were enrolled through a pharmacist practice-based research network called PearlRx, which is essentially a group of pharmacists that agree to be contacted and participate in research, whether clinical and evidence-based practices or kind of research on them as pharmacists and their work system. So I recruited them via email in that newsletter, in the PearlRx newsletter. And I was really interested in pharmacists' subjective experiences of fatigue and the factors that impacted these feelings. So conducted some interviews with pharmacists, and these interviews asked the participants questions about fatigue, including the changes or feelings that they noticed over the course of the workday. Because you can recognize that maybe when I say fatigue, it can mean different things to different people. So kind of fluctuating and varying kind of how those questions are worded to be able to elicit the information that I'm curious about. And I asked about things at work or at home that kind of promoted or mitigated these feelings. The interviews took about 30 minutes, and then our transcripts were analyzed with deductive content analysis. So in total, I conducted 39 interviews. Participants were on average 36 years old, with most of them identifying as women. Most participants were white and had worked as a pharmacist at their current pharmacy for about 3 years and consumed on average 2 servings of caffeine a day. Most participants worked either in a national chain or an independent pharmacy. Pharmacists reported working about 9-hour-long shifts on average. And interestingly, 70% of the pharmacists stated that they already received some sort of scheduled break within their workday. On a typical workday, most pharmacists had 2 full-time pharmacists staffing and about 3.5 full-time technicians, interns, or other staff members. And the participants' pharmacies really varied. They filled an average of 400 prescriptions daily, but that volume ranged from 17 prescriptions at one independent pharmacy. I can't even imagine only filling 17 prescriptions a day, to a national chain which filled 1,500 prescriptions daily. And so the SEEPS framework, which I kind of shared earlier and kind of built into my occupational fatigue framework, was used to describe these components of the work system. There's the person, the tasks, the tools and technology, organization, physical environment, and external environment, all which feed into these factors that might impact fatigue. So from the interviews, personal factors that contributed to the experience of fatigue were things like prior injuries, as well as I had a not insignificant portion of pharmacists that were also pregnant. Similarly, they identified things that can help mitigate fatigue, such as being younger, having a higher caffeine intake, past experiences and perspectives, as well as prioritizing well-being while at work and just having a general positive, enthusiastic outlook. There were also factors that were variable, such as kind of their life outside of work or having an outgoing personality. This is demonstrated in one of the exemplar quotes where this pharmacist talked about how their children are helpful to cope with feelings of fatigue. But if their kids don't get a good night's sleep, that can impact their feelings of fatigue while at work, which I thought was interesting. Regarding pharmacist tasks, participants identified that the volume of tasks, the type of tasks, the need for multitasking significantly contributed to their fatigue. These tasks were also influenced by COVID-19, which I'll kind of highlight when I get to the external environment. Pharmacists also said that doing tasks that they enjoyed helped to mitigate fatigue. For some, this was providing vaccines. For others, it was having meaningful interactions with patients. But sometimes this was complicated. When they were faced with like so many other demands, such as checking prescriptions or having a long queue, they couldn't spend as much time on the enjoyable tasks as often as they'd like. Pharmacist 36 described this mental exhaustion they faced when they were having to review a lot of prescriptions before they could even be filled. One of the number one pieces of technology pharmacists identified as promoting fatigue was the telephone, and that it was constantly ringing. Similarly, tools that pharmacists found helped to mitigate fatigue were comfortable shoes, playing music, and wearing telephone headsets that allowed them to move around and multitask. One tool that numerous pharmacists mentioned kind of in different capacities was the use of a call center as a tool. Some pharmacists described that it was helpful to offload kind of the massive amount of phone calls that they were getting, but other pharmacists described how it was often problematic. Like this pharmacist who said that the call center sounds like a good idea, but it's not. Because the call center doesn't know that we're behind on our prescription promise times, they tell the patients an unrealistic time, and then the patients show up and are upset and are mad, and kind of that leads to more problems. The next SEEPS component is the organization, which encompasses the culture as well as policies and procedures. A major organizational factor pharmacists identified as contributing to fatigue was staffing. So whether that's the lack of technician staffing or long hours that they had to staff or numerous shifts in a row, pharmacists mentioned kind of the struggles of keeping up with their work, given the staffing resources that they had. They described factors that help to prevent fatigue, such as coming in early, support from organizational leadership, and support from their coworkers. And the topic of breaks was mentioned kind of both as promoting and mitigating fatigue. It often depended on whether the pharmacist was able to take a break or whether they were able to utilize a break as kind of a real break. So this one pharmacist states in their quote about how technically they get a 30-minute break where the pharmacy closes for lunch, but that they don't use this time because they often use it to listen to voicemails or work uninterrupted, because it's the only time in the pharmacy where it's quiet enough to listen to the phone. So they emphasize the value of uninterrupted work time without distractions or interruptions or noise. But that's not the same thing as a break, right? And so it really kind of highlights a more systematic problem of needing to be able to work uninterrupted, in addition to being able to take a break, and kind of the lengths that these pharmacists will go to get their work done. The main physical environment factor mentioned was not necessarily surprising, with the requirement to stand throughout the day. Numerous pharmacists mentioned about how the use of stools or chairs was essentially banned without a medical excuse. And one pharmacist described about how stools are highly frowned upon, and the culture that you'd better be actually injured if you're going to sit down during the day. And then finally, many pharmacists mention kind of the impact of the external environment, namely COVID-19, on their work demands, their capacity, and their overall fatigue. COVID-19 increased the amount of work and tasks that they were now responsible to complete, from vaccines to COVID tests, and doing all of that while also managing kind of the decreased staff, or if folks were sick and had to call off of work, and kind of balancing that whole process. One of the pharmacists explained how the vaccines provided a quote unquote extra level of crazy, and how it was hard emotionally having to provide the immunizations to people who were upset about having to get vaccinated. I want to share a couple more of these themes regarding COVID-19, because I think I had a really unique opportunity during my dissertation to look at the impact of this global pandemic, and hopefully doesn't happen again, but thinking about kind of the implications on the work system. Another pharmacist described the difficulty of administering COVID tests through the drive-through, not only just the sheer number of tests and this number of new tasks that they had to do on top of their normal work, but because administering and running the tests took technicians out of the pharmacy for several minutes of at a time. And then finally, pharmacist 5, who described how community pharmacists were accessible, they were available, and they were ready to provide COVID-19 vaccines and meet the community's needs. And then all of the staffing left, which provided a really challenging problem. So now that COVID is over, kind of, now that we've handled a lot of those hurdles, there are plenty of other questions that we can answer. What are the patient safety implications of occupational fatigue, community pharmacists? We can speculate that there are likely errors, especially for pharmacists that have been working for 14 hours, that they're likely making some sort of error when they're checking the prescriptions or talking to patients. But being able to capture that and measure that and quantify that is a potential question. Additionally, what about other pharmacy team members? So looking at pharmacy technicians or student pharmacists and pharmacy interns, pharmacy clerks, they're all really important members of the team, and looking at fatigue in those populations may be interesting to be able to paint a picture about an entire pharmacy work system. And then finally, what can be done to eliminate or reduce fatigue, addressing this problem? I'll give you a couple of my thoughts that we can take away from human factors. Again, learning from other systems like aviation is a big one, and taking this work system approach, which is often summarized by fatigue risk management systems, or FRMS. And it really takes the systems-based approach, kind of like what I showed you earlier. And again, that fatigue is this balance related to work demands and capacity, or more aptly, the imbalance, right? So ideally, we would mitigate fatigue by balancing the scales again, or tipping it back in the other direction in favor of increased capacity. like this. So the first and most preferred way to do this is to reduce work demands, totally eliminating kind of that negative weight of workload. But maybe totally eliminating tasks isn't feasible. So maybe we offload tasks to other trained personnel, such as kind of the tech movement for final verification, or technician and intern immunizing. In theory, right, freeing up pharmacists time to do more clinical tasks and reducing their workload that way. But maybe you say, okay, Taylor, well, reducing the work demands isn't possible. Another strategy could be vastly increasing the capacity to do work, right? Pharmacists mentioned difficulties with staffing of technicians and even pharmacist hours. So, right, potentially looking at ways to hire, recruit, and keep new employees is another approach, kind of to improving capacity to offset those demands. And finally, you may say, Taylor, well, none of those are possible and they're not happening soon enough. So other strategies that are kind of lower on the recommended list for fatigue risk management systems, say that if you can't prevent fatigue by reducing demands or increasing capacity, you should at least attempt to mitigate or prevent those negative effects from fatigue from reaching patients and providing and, causing potential harm. So this may be having additional safety mechanisms in place, like alerts or barcode scanning, to be able to catch these errors from reaching the patient. Because again, we are humans, we make mistakes, whether we'd like to believe that we are, infallible as healthcare professionals, we are superheroes, we are a different breed, we're not going to make mistakes. That's not the case. We are all human and we likely make mistakes. And then finally, kind of the last strategy that's recommended is to just educate employees on personal strategies that they can use to cope with fatigue, like sleep hygiene and caffeine and mindfulness strategies. But we have to recognize that these kind of strategies are like putting a Band-Aid on a bursting dam. It doesn't really solve the problem. You're just trying to kind of cover it up at the individual stage without really solving any of the systematic problems that are causing it. And that's kind of the situation that often leads to burnout. When these problems and this fatigue goes unmanaged or unchecked for so long, of course, people are going to become, frustrated and worn out and just emotionally exhausted by their job without kind of reaching that no point of return. So some ways that I think this might look like, maybe scheduling. There are some unique kind of, whether it's shorter shifts, kind of looking at different scheduling patterns. There's also been some interesting work done in nurses and in aviation about, doing some sort of fatigue competency test before going in, dynamic scheduling to say that, okay, if I'm fatigued this day, there's a backup plan for someone else to go in and kind of tag me out. Looking at shift lengths, shorter shift lengths, it's always a plus. Opportunities for sitting, for one thing, but also moving around, the diversification of tasks or opportunities to focus on specialized clinical tasks that are enjoyable. There was an interesting study done of fatigue, forget when it was done or by who, but it looked at kind of fatigue across different professions. And it wasn't necessarily the jobs that were hardest that were most fatigued, but it was almost more of the enjoyability of the tasks and kind of the versatility of the tasks that really impacted fatigue. And then, kind of the addition of centralized call, verification, or dispensing centers. Again, that looks at kind of realigning and redistributing the work tasks so that they're in a different place, so that it frees up pharmacist time for other more enjoyable clinical tasks. And then additionally, this idea of breaks. But again, comes back to like, is it actually a break, or is it just something that's a break on paper, but the organization still expects you to kind of work through the break and get the tasks done, and if the patients are at the door pounding, you handle them. So there's a lot to unpack, I think, with breaks that goes a lot deeper. And so, I joke that I have job security, there's all these problems, but really I try and remember kind of why I do this research and why I'm so grateful to be able to do this research. It's really for the pharmacists and for the student pharmacists to support them so that they can do what they love in taking care of their patients. And so I would say for kind of the young professionals or the trainees or for those student pharmacists, whether you want to go into community pharmacy or you want to go into academia or really any job, thinking about how an organization or a system aligns with kind of your priorities and your future. What is their stance on kind of a workplace culture and work shift and kind of their kind of dynamic of how they support their employees, especially with regards to fatigue and burnout, from sabbaticals to breaks, and really thinking and making sure that aligns with your interests and your kind of thoughts in terms of well-being. Just briefly, if you really liked what I talk about and you're like, oh my gosh, I would love to do this in some capacity, just wanted to highlight some different opportunities. So for the PharmD students, that are thinking about experiential rotations, whether IPPEs or APPEs, there are experiences in academia and in doing research. But, even if you're on a clinical rotation, letting your preceptors know about your interests. For my inpatient APPE, I let them know I was interested in human factors, and they kind of posted me with the health IT team that was then rolling out the then brand new electronic health record. So I got to be involved with kind of the decisions that were being made on a system-wide rollout of an EHR, which was really cool. And really fascinating, but it was only because I had mentioned that and told my preceptors that was something I was interested in. There are numerous opportunities for internships, specifically within the realm of human factors. So this is at AbbVie, which is a pharma company, where their team supports the development and combination products and medical devices by using research and usability testing to ensure that patients, caregivers, and healthcare providers can safely and effectively use the devices to take their medicines. So another interesting kind of opportunity of, how do you design products so that people can use them appropriately? I had a patient once who was telling me about how, they were giving themselves all this insulin, but their blood sugar wasn't getting better. They couldn't understand. And they also had this new rash that developed on their arm. Come to find out that they weren't putting the needle on their insulin pen and were just they dialed it up correctly, were putting it in the right spot, but no one had ever told them that they needed to put a needle on it. And so thinking about those levels of design about, how can we do this so that folks can't make mistakes, essentially. In terms of residencies, there are certain residencies that are kind of getting into the field of human factors. So thinking about community-based research, with an emphasis on administration. Also, health system pharmacy administration also has kind of dives in a little bit into this leadership and this idea of systems-based evaluation. Also thinking about fellowships. So the University of Pittsburgh has one in community pharmacy leadership and research, where you kind of go through implementation and evaluation of enhanced community pharmacy practice models. Or UIC has their Health Economics and Outcomes Research Fellowship, which again partners with industry to look at more HUR and kind of pharmacoepidemiology and economics, but everything costs money, and there's always a way to think about how implementing these services or implementing these changes or errors related to fatigue can impact, the bottom line, and also thinking about what does it mean for industry. And then finally, if you are like, yes, I want to do this 110%, you can also think about graduate training, whether a master's or a PhD program, similar to mine that I went to at UW-Madison, their Health Services Research and Pharmacy program, or at UIC, they have their PhD in pharmacy in the Department of Pharmacy Systems, Outcomes, and Policy, and you can come work with me and do some of the work that I do, or many of the great faculty that are here. I do want to put in a quick plug. In my position, doing research as part of the director of the SCRIPS Lab, which is the Systems-Based Collaborative Research for Patient Safety. So if you are at all interested in some of the work that I've been doing or want to see more about some of this work with pharmacist fatigue or some of the other work that I've done in kind of health information technology, again, with this human factors lens, all of that is on my lab website, and you can kind of see what projects we're up to and see some of the outcomes that we've provided. And so with that, I'm going to spend the last bit to talk about questions that you have, kind of areas along your journey, and ways that we can kind of facilitate this discussion and learn together. So thanks so much.